chairperson is going to speak about something about Dr. Anshul Mittal, sir.
We now have the Dr. Mittal from pulmonologist, Max Smart Super Specialty Hospital. He's a graduate from Aurangabad and has done his PG from Rohtak. He has been senior resident in academic medicine and one of DM pulmonary and critical care medicine from Delhi University. Currently working as consultant in Department of Respiratory Critical Care Medicine at Max Saket Hospital. Has worked as a senior registrar at Sabdajan, worked as associate consultant in Medfor and JCS Institute of Pulmonary Critical Care Sleep Medicine. Have been nodal officer in central government team for inspection when H5N1 outbreak in Gujarat. Have been faculty at bronchoscopy workshop at Pentax India and faculty workshop on ventilatory management at IMA Prayagraj. It's a complex topic. They are going to deal about the lymph nodes which have been inaccessible for decades. So over to you.
Good evening, everybody. So it's an honor to be speaking in front of people who have seen the growth of this procedure through the ages, and now there is something new which is coming up every day in field of pulmonology. So here I would like to introduce a new procedure which is an IBUS guided transbronchial cryobiopsy. So IBUS has been long been there since 1999, as Swapnil told. Endobronchial ultrasound guided transbronchial needle aspiration, the IBUS TBNA, is a technique of choice even currently for studying of mediastinal and hilar lesion. Though initially it was started as a tool to stage lung cancers, now it is a diagnostic tool in both benign and malignant mediastinal masses. However, it being a needle procedure which only uses cytology instead of histopathology, there are issues of inability to obtain intact biopsy specimen which are fragmented and low volumes of sample size which our pathologists fail to comment on and leads to a non-definitive diagnosis. These sometimes require rebiopsies or additional diagnostic procedures such as mediastinoscopy and VATS when the tissue needs is higher or diagnosis eludes us. So this is some of the drawbacks I would like to state of the IBUS TBNA. So when IBUS TBNA was evaluated for a diagnosis of primary or metastatic pulmonary malignancies, so it has been an excellent diagnostic tool. But again, it being a cytology procedure, retrieves a limited amount of tissue that might be insufficient to allow absolute diagnosis, specifically in case of rare or benign malignant tumors, which frequently requires a histopathology sample rather than a cytology samples. So in recent year, lung cancer has gone heaps and bounds above the other cancers. We are having newer drugs each day. So proper molecular characterization of tissue sample has become crucial in management of thoracic malignancies. Newer drugs are added each day which require molecular testing and increases the need of tissue by pathologists and medical oncologists, which is usually not possible by a cytology procedure like IBUS, and patient ends up going under another biopsy procedure. When IBUS was evaluated in use of lymphoma, so IBUS as a tool to diagnose lymphoma and subtype it has been of question since its advent. The recent research is highlighted that histological sample rather than cytological samples are required for diagnosis of lymphoma. Histological sample not only helps in diagnosing, but proper molecular application of biomarkers helps to plan the treatment further and better. In case of mediastinal lymphadenopathy and suspicion of lymphoma, still by the medical oncologist, surgical biopsy is preferred as the diagnostic tool. For the good old sarcoidosis versus TB, which is the most common indication for IBUS worldwide, at this time, several groups have addressed the use of many modalities to increase the yield. We use the rapid on-site examination. We have used higher gauges needle. We started with 25. Now we have a 19 one also. The number of passes have increased. 3 passes we have changed to 5, 6. And we try to sample as many nodes as possible so that the tissue is higher and the definitive diagnosis has been made. So if we compare all the studies which have been done on this system, still around 20% of the IBUS done in the highly trained setup fail to detect a granuloma, or even a granuloma. We are not able to differentiate between a TB and sarcoid on a definitive way in a setting like us. So for all these reasons, now there is a need for a procedure which is less invasive than mediastinoscopy and VATS for getting a histopathological tissue, is beyond cytology and cell block, which we use in EBUS to make a diagnosis, and gives a larger volume of sample which satisfy the needs of our medical oncologist, because their need of tissue is growing day by day, I guess. So I introduce a procedure which is called EBUS guided mediastinal cryobiopsy. So before we go to the actual procedure, I would like to brush up the knowledge of cryobiopsy. Cryobiopsy has been there for now quite long, which utilizes the cryoprobe, which uses compressed gas that decompresses within the metallic tip of the probe and causes a cooling effect. As the result, the tissue around the probe gets freezed and can be extracted. Two main cryogen are available, the gas, carbon dioxide and nitrous oxide. Cryoprobe are available in three sizes. There is a 2.4 mm one, which is the largest one, which is usually used to extract the foreign bodies, blood clots or mucus from the tracheobronchial tree. There is a 1.91 which is used to do biopsies from the lung or endobronchial tissues, and there is a 1.1 which is now available as a disposable one, which was initially done mainly to do pediatric lung biopsies. Cryobiopsy as a procedure has been applied to good effect for detecting ILDs, doing transbronchial lung biopsies, for removing foreign bodies, blood clot, mucus, for biopsies of the endobronchial tumor, for biopsies of the small pulmonary nodules with use of fluoroscopy, radial EBUS, navigational bronchoscopies, or currently the newer thing, the cone beam CT. The complications of cryobiopsy include pneumothorax and bleeding inside the endobronchial tree, which was initially in the studies 9.5, 4.9%, but all these complications have come down drastically with more experience and more expertise we have now in technique. So how to perform a mediastinal so as good as the term looks, it's a bit of a tricky procedure to perform a transbronchial mediastinal cryobiopsies. So I will just tell the basic steps which needs to be done. So we start with an EBUS. We identify the lymph node station as we do in all the EBUS. We perform 3 passes through the TBCNA needle at the same site. So the importance during passing of the needle is it should at the same site in the bronchial wall and at the same site in the node. We should not change the sites frequently. After we have done 3 passes, the key is to identify the tract of the TBCNA needle within the lymph node. So this is the TBCNA needle which is creating a hole in the wall of the bronchus, and this is the needle inside the lymph node which we see. Once the needle has, once we have created the tract, we try to push in a 1.1 mm cryoprobe through the working channel of the EBUS. So this is the probe which comes out through the working channel of the EBUS. The cryoprobe is advanced towards the puncture site and inserted gently through the puncture site by the needle. The EBUS image is used to confirm the cryoprobe location within the lymph node. Following this, the cryoprobe is cooled like we do in the biopsies for a 4 second, and then we can retract it en bloc with the scope. So a good amount of chunk of the tissues comes out of the needle. So this is the hole which we visualize in the tracheobronchial wall, and this is the tract which we see, which has been created by the use of the needle. And then once we have done it, we pass the probe inside the through the bronchial wall into the node, and this can be easily visualized using the EBUS. So the good thing is we have a correct visualization of the probe, and you have the vessels also localized. So you can always be away from the vessels, and you have a correct localization of the probe inside the node, which makes it a real-time visualization procedure. We are not blind anywhere. So the cryobiopsy, once we remove the probe, en bloc with the scope, we remove our tissue, and we again inspect the site for any major bleeding. The cryobiopsies can be retrieved in formalin or saline according to the tissue. So this is the amount of tissue which usually get attached to the scope. These are real-time photos, and this is the tissue. You can look at it. We cannot get this amount of tissue from the mediastinal nodes by any kind of an EBUS, maybe whatever needle we use. And these are intact tissue, which our pathologists find it very well. So this is one of the videos. How does it play? How does it play? नहीं प्ले करना पड़ेगा 1 मिनट नहीं प्ले हो जाएगा डायरेक्ट. So this is one of the real-time case which we did recently. I am demonstrating. So this is a mediastinal mass. So this is the needle which we have put through the channel of the scope. through which we are trying to create a tract. The important is to jab the needle a bit with the force, and we have to do it from top to the bottom. We take out through the tracheobronchial tree, we again insert in the node, we take out through the tracheobronchial tree, again inserting into the node. So important is you do your Rose passes before we start at transbronchial mediastinal cryobiopsy. It is only to be done when we have completed the IBUS. It should not be done as a first procedure because the needle will get damaged otherwise. So once we have done the passes, now we can see a tract within the node. So now we try to introduce our cryoprobe into the node. So it's a soft procedure. You put it into the cryo, you touch it at the wall and you try to jab it slowly. Because slowly the probe will pass. We can see that it's trying to coming out of the upper part. So conventional to the belief, it's more tricky to go through the node. Going through the bronchial wall is very easy because already a tract has been created there. The tract localization within the mass or within the node is the difficult and the tricky part here. So you will just see the probe. So once you have pushed it, the probe, the tip of the probe is usually brighter than the tip of the needle. So you will just, it will just be visible. So here we see, this is the tip of the probe. We are very well confident it is inside the node and we know these two are vessels. We try to keep it away from the vessels. See, this is clear cut the probe and you can move it up and down. You can take specifically in lymphomas, they want a biopsy from the periphery of the lymph node. If you take a biopsy from the center of the lymph node, you might miss the marginal zone lymphoma which they want. So it's very important you take the biopsies from the periphery, from the downside and from the up, from the middle. So we try to take biopsies from all the places. So as easy or as difficult as it looks, there are some technical difficulties with being a new procedure. Only few centers in India doing it and few people have been able to do it on a regular basis. The issues are regarding creating a tract, which is more frequently seen in cases. So we have the problem which I have found once we have started this procedure is calcified nodes. Patient has taken ATT for 2-3 months, nodes are calcified. In a calcified node, creating a tract is a big problem. Even if you create a tract, passing the probe, 1.1 mm probe, which is a very flimsy kind of a wire, which breaks easily through the node becomes a challenge. One place more which we have found a problem is when the bronchial wall is rigid and the cartilage becomes rigid, specifically in old age patients. They're creating a tract through the wall of the bronchus was a more of a difficult thing. Whenever we created it, got close. So it was one of the problem. So how to create a tract? Different people have tried different needles. There have been studies with 22G, 21G, 19G. Initially when we started it, we started with a 19G. But the problem with 19G is you get a very bleedy sample on Rose. So now the last 15 cases which we have done, we have all done with a 21G. So there is no need of a higher gauge 19G needle now. There have been studies in which they have used that, when I was in Bangkok, they were using in Thailand, which we were seeing the procedure, they were using the cautery knife to create a hole in the tracheal wall. But never ever, after doing good amount of cases, 20-25 cases, have I required to create that hole. 21G needle works enough. 1 or 2 times we have to use a 19G needle, which we usually keep in backup. So like IBUS TBNA, TMC can be done under short GA with use of an LMA. It can be done under your bronchoscopy suite. An occlusion blocker we usually keep on a standby. If needed, can be put if there is case of a bleeding. Not needed till now. In all the procedure we have performed, till date we have not noticed any major bleeding, pneumothorax or pneumomediastinum in any of the cases. The most common adverse effect which you saw was bleeding into the tracheobronchial tree, but that was controllable within few minutes, manageable in all the cases. So there has not been many supportive data for TMC, it being a new procedure. So this is only the one of the large study in which they include the 50 cases, which was recently published in ERJ in 2023. In there they found TMC was an effective, minimally invasive, rapid, safe technique, which yielded a higher diagnostic yield than IBUS TBNA, especially in cases of lymphoproliferative disorder, metastatic nodes, where the biopsy sample need is higher for molecular diagnosis. So, for better understanding, I would like to present 2 cases which we have done very recently at our center. This was a 36-year-old male, the usual history of fever, weight loss, loss of appetite for 2 months. Outside CT scan showed mediastinal lymph nodes, ACE level were normal, TB gold and Montlux was positive. At an outside center, patient went under EBUS TBNA, which was suggestive of granuloma. All TB markers, gene expert, AFB stain culture were negative. Patient was started on empirical ATT. So this is his PET scan. So we did a PET scan here. So this was a PET scan showing a plethora of lymph nodes within the mediastinum. Patient was not happy with the TB treatment given. Neither there was a much of a response. There were two options. Either we go for a mediastinoscopy or a EBUS VATS. For a VATS, which was invasive, so we gave him a second option of an EBUS transbronchial mediastinal cryobiopsy. So like every EBUS, we did a ROSE. Our ROSE or our pathologist gave granuloma, but the same problem, no necrosis, no caseation could be commented. So again, there was a gray area that TB hai, sarcoid hai, dono hai. So then we did a TMC. So this is a TMC in which the cryoprobe is inside the node. We got a good amount of tissue, and on TMC, the pathologist could clearly comment on a multiple non-caseating epithelioid granuloma, which are the telltale sign of sarcoidosis. Patient started on steroids, ATT stopped, and patient is doing well. This is an international patient which we did recently. 58-year-old female with a cough and weight loss and hemoptysis. Evaluated in Iran, there they got a sputum positive report, they put her on ATT. Then they referred to India because she was not getting any benefit from it. She was progressively deteriorating both on radiology and clinically. So this is the PET CT scan. So our medical oncologist thought that there might be an endobronchial lesion. We also thought that. We went inside, there was no endobronchial lesion. The lesion was far away from the chest wall. Doing a CT guided biopsy would have given her a pneumomediastinum or a pneumothorax, which was also considered. So again, a transbronchial mediastinal cryobiopsy was planned. First we did a ROSE. In ROSE, there were non-small cell cancer. So cancer was confirmed, but pathologist wanted a higher amount of tissue, do his all the molecular markers. So again, we inserted a needle, we made a tract, we inserted a cryoprobe. Through the cryoprobe, it came out to be non-small cell carcinoma. Tissue was adequate for IHC and molecular testing. Patient turned out to be adenocarcinoma, EGFR positive. So my take on TMC would be, it's safe in lymph node size of 1 centimeter in experienced hand. I have not tried more than 1.2 centimeter, smaller than 1.2 centimeter. Definitely a better yield in lymphoma or rose negative lymph node. Adequacy of sample is higher, ensures the correct diagnosis of malignancies with IHC and molecular testing. It is less evaluated for benign hands, but benign lymph nodes, but wherever we have tried, the success has been good till now. No major bleeding or complication has been seen till now. Looks a promising technology, which will with further data and studies being added. Swapnil is one of the guy who is doing a study on it as his DNB thesis. So very soon we will have more data and we can be more sure about how this procedure is going to go further, but I think it's here to stay. Thank you.
Thank you. Wonderful. Great presentation. We'll have given an option, as you said rightly. Would you go for a mediastinoscopy first? Would you go for a EOBS first? Or will you go for a bronchoscopy first in these patients with mediastinal growth?
So with mediastinal growth, we always go for an EBUS, which is the standard technology. Right, is mediastinoscopy, I think now nobody is doing much. Even at our center, I think surgeon might not be confident because he has not done it since past 10 years. It was not required. But with the current era of medical oncology, they want higher amount of tissue. They want to do all their molecular marker. One of the report I saw, it was 136. I don't know, they have a treatment to it or not, very confidently to the all. So they want a larger amount of tissue, which is not possible by EBUS because it's cytology procedure, give a small amount of tissue. So
one question out of contest. Do you still believe in TB gold test because this is no more academically accepted? And but done otherwise very frequently. So do you accept it?
Sir, it is not a marker for treatment, but it is an ancillary evidence when there is a confusion. So I will take it as an ancillary evidence rather than being an actual test for starting a treatment.
Thank you. Thank you, Dr. Anshul Mittal. It's a wonderful presentation of EBUS and very good presentation. So message is very clear. If you are having mediastinal lymph node in your patient, on the basis of Montoux or TB cold should not start ATT. You have to confirm by EBUS. And other modality is definitely cytology is, if you are not doing, anybody is doing EBUS here, at least do cytology, FNAC. If that is wonderful to do the histopathology with the 21 gauge needle, and it's definitely the two techniques like previously they were using the electrocautery knife to give a passage, to mark the passage in bronchial tree, but that is lead to sometimes more bleeding. The important thing is when we, in Indian settings, when you are finding the lymph nodes, sometimes more of the time 90% or 80% you can find the tubercular lymphadenitis. The high chance with histopathology, If you are getting the FNAC expert gene, and you can send and get if there is positive. Sometimes you can find the tract can lead to the sinus formation and can lead to the puncture in the tracheobronchial in Indian setting. But if you are doing rows, that rules out the tuberculosis, and that is an important thing, important message, because one of my colleagues having 2 cases, the mediastinal lymph node rupturing in the tracheobronchial, converting into the mediastinal abscess. So we have to be very careful. If you are finding EBUS, there is a caseation, necrosis, then definitely you should avoid. If you are having solid tissue like mass, lymphoma, that is a wonderful, if you are getting sarcoidosis. Again, question is improved. That leads to chronic sinus discharge. After a few months, patient cough out these purulent secretions, but the thing is mediastinal abscesses, that's difficult to treat. That is a complication. So in Indian setting, we have to, but you are doing wonderful job, but doing rows and taking all precautions, then avoiding this just message. So
sure, sir.
It's wonderful.
So first I wanted to congratulate Swapnil. Swapnil, I know how difficult it is to do a presentation in front of an audience who are all senior to you, and to stand up on a stage and make a presentation and speak confidently speaks volumes. So I think there should be a big round of applause for Swapnil for being as brave as you have been. Very good. Anshul, lovely presentation. Very nice to see your passion. I just have a couple of comments to make. So we've just reached double digits doing the procedure that you've described, and one of the challenges I have faced in executing it is that I've always found the 1.1 probe very floppy. You know, the end flops around a lot. So irrespective of whether you're doing a cryobiopsy or whether you're doing a mediastinal cryobiopsy, it always ends up being very loose, lax end of the probe, and to introduce it to the track becomes a bit of a challenge. So in lines with what Virottam said just now, what we do is we have access to rows. So if we find a malignancy, be that a lymphoma, be that a lung cancer, we would actually try and do it. But if there's any other diagnosis where we don't really need extra tissue, we probably won't go ahead and do it, because like you said, it's a procedure which actually requires quite a bit of skill and probably is 3 notches above doing an EBUS in my experience.
So it's an add-on. So I would say that, sir, it's an add-on procedure, not required in every EBUS. You should start with an EBUS. If your EBUS is not giving you a definitive result and you need a higher volume of tissue, then it's an add-on procedure. Luckily, it does not require any other add-on equipment except for the 1.1 mm probe.
We are using the Olympus system.
So we have an Olympus system, and the 1.1 mm probe is standard. I think Arbase has patent on it. That is that only.
Good. Wonderful. Thank you, Dr. Your name is? Swapnil. Wonderful presentation. Thank you, Dr. Anshul. Wonderful presentation. And
thank you,
let's good applause.
Thank you, Dr. Anshul Mittal sir and Dr. Swapnil. Now I would like to call our organizing secretary, Dr. S.K. Pathak sir, to present memento and bouquet to Angvastram to our speakers. Better speaker, yeah. Dr. Anshul Mittal sir. Definitely, sir. Dr. Swapnil Pathak. एक और लो. Now Dr. Anshul Mittal sir. Abhishek, chairperson. We would like to give memento to our chairpersons also. So I would like to call Dr. M.K. Srivastav sir to present memento and Angvastram to Dr. Virottam Tomar sir. Chairperson. Now I would like to call Dr. Akhilesh Singh sir to present memento to Mohit Bhatia sir. Dr. Akhilesh Singh sir to Dr. Mohit Bhatia sir. Would like to call upon Dr. S.K. Pathak sir to present memento to Dr. K.K. Tripathi sir. Padma Shri Dr. K.K. Tripathi sir. Thank you, our speakers and chairperson.